Welcome everyone to this WHS side event called Breaking the Silos, Primary Healthcare as the Bridge between NCDs and Infectious Diseases. Good morning everyone. My name is Rodrigo Scotini. I'm the Executive Director of the Infectious Disease Alliance and Director for the Primary Healthcare Coalition, which is hosting you today. The Primary Healthcare Coalition is dedicated to host this event today on how to strengthen primary healthcare systems to address the complex health challenges of our times. The Primary Healthcare Coalition was launched at the World Health Assembly earlier this year in an event joined by some of our partners here today, such as UNICEF, Sightsavers, and Amref. Over the next 90 minutes, we will explore how integrated primary healthcare can serve as a foundation for stronger, more resilient systems, linking prevention, care for both infections and non-infectious diseases, empowering communities and ensuring that no one is left behind. We have an incredible lineup of panelists who share their insights, helping share ideas on this topic, followed by an interactive and engaging Q&A session. So today we are honored to be joined by two distinguished keynote speakers, Anamaria Bejar, Director of Public Policy Engagement at GAVI, the Vaccine Alliance, who share insights on from infections to prevention, integrating immunization into NCD and public health responses. And the other keynote speaker is Dr. Fouzia Shafique, Associate Director for Health at UNICEF, who will speak on health and equity, integrating NCDs, infectious diseases, and community systems through primary healthcare. Their perspectives will set the stage for our panel discussions and interactive Q&A. The Primary Healthcare Coalition welcomes our members, new members, and all of you. I have some slides here to show. Yeah, just turning it on now. I think you're going to see my face in the beginning as the host of the event. Yeah, I can talk a little bit about the Primary Healthcare Coalition, which is, yeah, as I said, the hosting of this event. So the vision is a world where primary healthcare is universally accessible, integrated across sectors, and responsive to the needs of every individual. And the mission of the coalition is to unite stakeholders from civil society, government, private sector, multilateral actors, advancing integrated primary healthcare as a core pillar for national and global health strategies. Yes, the objectives that you can see here are mostly focused on advocacy of increased financing and better policies for primary healthcare, promoting equitable services delivery, generating evidence and disseminating through events, strengthening community health-based systems, and championing scalable innovations and sustainable solutions that enhance primary healthcare delivery and impact. So, yeah, I'll just jump this one. I can talk a little bit at the end. So from infections to prevention, integrating immunizations in NCD and public health responses, will be the presentation of Anamaria Bejar. Has she been able to join us yet? She's here. Thank you. Welcome, Anamaria. You're the Director of Public Policy Engagement at GAVI. Welcome. The floor is yours.
Good morning, everybody, and thank you very much for the organizers for inviting GAVI to this very important event. So it's really an honor to be here to try to discuss with you the links between infectious diseases and non-communicable diseases. We do think as GAVI that the linkage between infectious diseases and non-communicable diseases is sometimes overlooked. And unfortunately, because of how our sector works, we are working in different communities where there should be much more and stronger links among each other. So I'm going to set the scene for this event. And of course, we all know that NCDs are the leading cause of death, morbidity, and disability in the world today. As many of you are aware, despite good progress being made since 2018, the global burden of the NCDs is continuing to rise. So the trend is going up. I don't know if I can, sorry, I need to go to the other, right? Sorry, I don't know. Yeah. So as you can see, NCDs account for 71% of global deaths each year, unfortunately, and is translating more or less on 41 million lives lost annually. Imagine the population of a specific country. I'm from Peru. My country has about 30 million people, so it's kind of seeing my compatriots dying every year because of NCDs, and that's more or less the proportion around the world. In 2021, 7 of the top 10 leading causes of deaths were NCDs, and in low and middle income countries carry the highest burden of disease. So 82 of these deaths occur in these countries, in low and middle income countries. And basically, as we all know, due to lack of access to health services and essential medicines, And of course, as a consequence, NCDs also contributes to poverty due to the high costs of the health services that some families cannot afford to take. So, as you know, also the figures on universal health coverage is that what we call the catastrophic expenditure, which is the money that some families need to spend on health that really push them to poverty, is also caused by the high burden of NCDs. You have some figures in front of you. But this crisis is taking place in a background of really resources being reduced for health internationally. And every country also nationally is facing biggest challenges, the biggest challenges of the last few years in terms of deaths and their capacity to cover the costs of health. We all say that being ODA declining is the domestic budgets which need to pay for health. And we all believe in that, and we should continue advocating for that. But we all know that also countries are facing huge financial challenges, most of them due to the debts that some countries have. So it's not an easy answer. So there is a crisis in front of us that we need to face. So the growing burden of NCDs is a threat that requires the use of all effective measures to prevent and control. And as I was saying at the beginning, the link between NCDs and infectious diseases is really overlooked. The latest research estimates that 8.3% of the global burden of NCDs have been attributed to infectious diseases. And for example, chronic hepatitis B virus infection resulted in an estimated 1.1 million deaths globally in 2022, and mostly from cirrhosis and primary liver cancer. And it's the second and fourth largest contributors to the global burden of NCDs, respectively. And the human papilloma virus, HPV, is a direct cause of cervical cancer. And as you know, cervical cancer, for instance, is the highest cause of death in Africa for women. And is one of the most common causes of cancers in women around the world. It's the fourth in the ranking of cancers, and it's a lot of mortality in middle-income countries. It's 82% of women dying because of cervical cancer occur in low and middle-income countries as well. So important to look at the inequities. We have, this is more or less a graph to show you the distribution across the world of infectious diseases that contribute to cervical cancer. So, as you know, I work in GAVI. In GAVI, the Vaccine Alliance is a public-private partnership. We are a funding mechanism for vaccines for the 57 countries which are eligible to GAVI funding. And we exist since year 2000. We have contributed or supported countries to vaccinate 1.2 billion children since 2000 and saving 17 million lives. And as I was saying, the links between these specific diseases and NCDs is a very important one, and we have vaccines to prevent those diseases. We have, you see the antigens in the column at the center part. We also have all, other vaccines that contribute to diminish some of the NCDs, but most directly is the hepatitis B vaccine, the burst dose, which prevents liver cancer, and very importantly, the HPV vaccine, which prevents cervical cancer, that we are helping countries to finance. And our finance go for the vaccination of adolescent girls. We invested quite a bit of resources to reach the target of vaccinating 86 million girls by the end of this year. And HPV is a most effective vaccine in our portfolio. The effectiveness is 92%. So it's a very important vaccine, and as you can see, it can be really a game changer in preventing cervical cancer. So we have been really advocating for the recognition between infectious diseases and non-communicable diseases. We also, as I was saying, have other vaccines that are not that direct, like a Hep B and HPV vaccine, but vaccines against meningitis, measles, and polio prevent also some chronic conditions, as you can see in the slides. Of course, by preventing cancers and disabilities, it's not just, of course, a health outcome, but also relieve the pressures in health systems. We strongly believe that it's not just preventing NCDs, but having strong immunization systems will help to strengthen primary health care all over the world. Also in terms of global health security, for instance, no? When you have a pandemic or an epidemic or outbreak coming up, if you have a strong immunization systems, you will probably have a stronger primary health care. And also the possibilities for integration with other services are crucially important. No? Immunization provides many touch points throughout the first year of life of children, and those are all opportunities to prevent also NCDs. We always say that vaccines are just one part of strategies to control some diseases. So vaccines are not a panacea. To prevent cervical cancer, we also need screening and treatment, as well as for malaria, for instance. We know mosquito nets, we know the preventive prophylaxis. So we need to work as a sector, and I would think even beyond the sector. GAVI has as one of its main missions, apart of course to achieve vaccine equity and the sustainability of immunization, is to reach the zero-dose children, which are 14.3 million children in the world with no vaccine whatsoever received in their lives. And most of them live in fragile and conflict areas. So we dedicate many of our resources to reach them. Those are also opportunities to check the existence of infectious diseases in their mothers, in the family, or the carers who are bringing them to the immunization center. So very important to look at integration, and also to work from the perspective of health systems, which means that immunization needs and NCDs strategies need to be part of the national health strategies and the strengthening of governments. Civil society participation is absolutely essential in this effort, and so it's a very, very important advocacy goal we have to integrate all services around immunization that can be possibly do. Even if you think about fragile and conflict-affected areas, the need to integrate services goes beyond health, because the people who will need shelter, water, nutrition are the same people who will need immunization and the same people who will need screening against NCDs. So that's really our main ask for all the sectors, to integrate, to work together, and to try to overcome the financing challenges that are really affecting all of us. That's a photograph of our CEO, Dr. Sania Nishtar. She participated and spoke in the high-level meeting on the NCDs in the UN General Assembly this year. And we successfully advocated to incorporate the responsibility of the immunization sector towards NCDs. And we hope that the political declaration will be adopted later this month, after the hiccup that had in Anga. So all to say, just finishing this keynote, that our message is that we need to work much more together that we need to serve the same population, and the relationship between infectious diseases and NCDs and the power of immunization really needs to be taken forward for the wellness and health of the people we serve. Thank you very much.
Thank you very much, Anamaria, Bejar, for your important thank you words, and on the link between NCDs and infectious disease. I think it's a good setup of scene for this discussion of today. As the next speaker, I would like to invite Dr. Fouzia Shafique. She's the Associate Director for Health at UNICEF, who speak on health for equity, integrating NCDs and infectious diseases and community assistance through primary healthcare. Yeah, welcome, and your floor is yours.
Good morning, everyone. I am really happy to be here and to be starting my second day of the World Health Summit with all of you. It's a good way to start the day discussing something that's increasingly becoming very close to what we at UNICEF and many of you in the room are trying to do. I don't think I'll be sharing anything with you that you don't already know, but hopefully just bringing up some issues that are common interest for all of us, and that would help us maybe in the panel discussion start thinking about some of the solutions. Also to admit that the solutions are nothing extraordinary. All they require is for us to truly come together at the country level when we are trying to help the ministries of health and support them in doing what they alone can do best. And so there's no scientific discovery to share here. There's nothing aha. It's just truly not just saying things that we do at the World Health Assembly and World Health Summit around coming together, but actually coming together, in which I think is the biggest solution on how we can do this. And I know it's a technical agenda of how we bring our approach to infectious diseases and our approach to NCDs together, but it's, as you mentioned in introducing me, it's also a matter of equity and resilience and justice for children from where we at UNICEF are looking at it. So just very briefly talking about what we celebrated last year. After almost 25 years of UNICEF, Ministries of Health, GAVI, Global Fund, a dozen other partners really focused on this work. After 25 years, we were finally able to celebrate that the number of children who die before they reach their 5th birthday has been halved. And even as we were celebrating this success, we were also looking at it and saying it did take us way too long. 25 years is a long, long time with all that we have available in our hands nowadays. And so we celebrated a 45% reduction in the number of children who die before their 5th birthday. We also celebrated a 60% reduction in the number of children who are malnourished, so huge success there. But the work still remains. 4.8 million, 4.9 million children dying before the age of 5 is still something that we need to continue to work on. But we are also realizing that our threats no longer are just infectious diseases. In the last decade, increasingly we've realized non-communicable diseases are not just an issue of adult population. They're just as much an issue of children as well. And of course, I'll focus on children. I'm UNICEF, and so can't help but talk about children. Yes, so to look at the NCD situation in children, we don't need to spend too much time on the numbers, but just generally speaking, when you think of NCDs as a disease burden in children, you would expect that in under 5 and in under 19, you would see a sliver. And you don't. If you look at that blue line down there that talks about the burden of NCDs in children, it's pretty thick. It's not a sliver. And when you look at the 15 to 14, and imagine in the green part of the 15 to 19, it's a pretty significant burden of NCDs that we see in children as well. And on the right side of the slide, we are looking at high-income countries and then upper-middle-income countries and low-income countries. In the blue, you see the infectious diseases. And as expected, in least development countries, the burden of infectious diseases is higher. Children are still dying of things like pneumonia, diarrhea, and respiratory illnesses. But as countries control that and as their situation improves, you see that the red bar is reducing, but the blue bar is reducing, but the red bar is increasing. And the red bar is what reflects the number of children that are dying or suffering from NCDs. And so it's not just a problem in high income countries, but also in upper and lower middle income countries as well. And so very much an issue of children as well. Those of you who were at the World Health Assembly, at the UN General Assembly earlier this month, may have noticed that one of the highest level events was around NCDs, and the call that UNICEF and many of the countries and many of the partners, some of you sitting in the room, made was, we cannot have an NCD conversation without having children at its center, because that's where you need to do early detection, diagnosis, early care and management, so that you prevent suffering and you prevent death in children as well. And so traditionally, when we would look at what do we as UNICEF and partners who are interested in maternal, newborn, and child health would need to do, we would look at the left side of the slide. We would talk about the biggest killers of mothers, of newborns, and children, and say this is where our programs need to focus. But now increasingly we are realizing that of the 4.8 million children who die, many are dying because of non-communicable diseases. I'll just give one example of sickle cell. 500,000 children are born with it, are left undetected, and half of them die before the age of 5 because they're not detected or not getting proper care. And that's just one NCD. And NCD is a long list. So there's a significant number of children who are dying because of NCDs. We know that 1 million children at least die because of NCDs between the ages of 0 and 19. And that we know that almost half the children who have NCDs are not even identified on time for them to get the care they require. And as you go down in the category to the upper middle income, low middle income, and the low income countries, the higher are the chances of a child having these symptoms and suffering and never being detected. And then finally, the changing climate situation is another peril. I don't need to speak much about it. It's being spoken about everywhere, but yes, thank you. So we know that climate change is reshaping the disease patterns. We are witnessing expanded zones of vector-borne diseases like malaria and dengue, and we are seeing greater risk of other zoonotic transmissions as well. And at the same time, the heat stress, the respiratory illnesses, the food insecurity are also increasing chronic vulnerability amongst children. So respiratory diseases, diarrheal diseases, antimicrobial resistance are intensifying, and children again are very often seeing more than their share of suffering because of these changes. And therefore, a lot of overlapping vulnerabilities between infectious diseases, non-communicable diseases, and the impact on both of those of the climate crisis that we are seeing. And so, thank you. So, now talking about bringing non-communicable and communicable diseases together. So this is how we think about it when at UNICEF we sit down and we make our, take our white flip charts and look at it. And I'm sure many of you are doing this within your organizations as well. Traditionally you would look at the continuum of care along the service delivery level. How do you make sure that a child has care, irrespective of what it is that you're providing care for? At home, within the communities, at the primary healthcare level, at the secondary and at the tertiary care level. This is what you're seeing around this. So this is the continuum of care around the service delivery levels, and then the continuum of care along the life of the child. And as you will see in these various bars that you see below that, the diseases don't follow the age patterns, right? So they don't follow the pattern of newborn and the under 5 and the 5 to 9 and the 10 to 19. And therefore, you see a lot of overlap between these different things as well. And that's why at UNICEF, we look at the continuum of care along the life stages as well. How do we make sure that care is available to the child based on the life stage that the child is going through, or the mother as an adolescent or an older mother is going through, and then how do we combine all of it in one place? Now, as a refresher, reminding us of how we look at primary health care when we are looking at it as WHO UNICEF within the primary healthcare operational framework. So there's 3 things to it. So if you could first maybe look at the bottom of it. the traditional health system strengthening approach. What is it that we are trying to do when we are talking about health system strengthening? We are talking about having right people trained accurately. We are talking about having financing available. We are talking about having services available. We are talking about having quality of care. Now, the reason I read these out is because very often, as donors, as partners, as UN agencies, as coordination forums, we are looking at an issue and then trying to address that issue, instead of looking at a person and seeing what does that person want. So when we, as malaria people, go to a country, we are only interested in, are people trained in malaria, are the malaria commodities available? Then our immunization colleagues will come and they'll say, is the vaccine available, and is the vaccinator training? And then somebody else comes and says, you know, are we doing enough for mental health? So we tend to do this differently, not realizing that the health worker, well, we do realize it, of course, but not realizing that for a district manager, how difficult it is to have 27 of us showing up with 27 issues, which in the end impact the same health worker, requires the country to have the same essential drug list, same supply chain that provides it, same HMIS that has to monitor it. And that's why I was saying there's nothing that I'm saying that you don't already know. I think it's more that we talk about these things at global forums, but when we go down to the country level, we become so much a champion of what we are there for, malaria or mental health or vaccines or pneumonia or diarrhea, that we forget the child, we forget the mother, we forget the community, we remember the issue, and we forget to keep the child at the center. So to say that irrespective of what we are championing as an issue, it is in the end the same health workforce, the same data systems, the same supply chain, the same district manager who has to manage it. So if we could come together at the country level and work with the ministries of health not to cause fragmentation, but to do this in a comprehensive way, that's the way to address the divide that we have between the infectious diseases and the NCD approach. And then on the other side of the slide is community engagement. I won't go into details of that except to say there is more than enough evidence that unless communities are engaged, unless they are empowered, unless they are informed, it is impossible to get the results that we want. We might temporarily get it, and you know, immunization is a very good example. You can always do an intensified immunization campaign and reach for one time that high immunization coverage, but if the community has not been engaged and is not aware and is not empowered, you will need to continue to have that intense effort. If you want to not put in that intense effort and all that funding, then the way to do it is to make sure that the community realizes how important it is. And if you do that, then the whole process becomes easier. And then on the other side, we all know that health is an issue of multiple sectors and not just health sector working on its own. I won't go into detail, but I encourage everybody to look at this tool that WHO has developed with inputs from many of the partners, which looks at, again, those individual interventions and how do you deliver those interventions in a manner that it can be delivered within an integrated PHC framework. And then finally, talking about community health systems. And again, why are community health systems important? We've all been tracking the ODA situation globally and the impact it has had on countries. There is enough evidence, including the Black et al. Study of about 5 years ago, that shows that if you have properly financed, properly supported community health systems, then you can prevent at least 47% of all newborn deaths and 97% of all deaths that occur in children between 1 and 59 months of age. And so at UNICEF, one of our corporate priorities is at the primary healthcare level, focusing on community-based primary healthcare and therefore on community health workers to make sure that they are properly trained and that their training includes all of the issues that all of us want to champion in one place, and that there is proper referral system moving onwards, that their domestic resources are and that they are properly mentored throughout the process. Could you help me go on? It's not moving on my side. Next slide, please. Yes, and this is my last slide. I know you're worried about the time. So when we look at the countries where infectious diseases for children continue to be a primary concern, there's a list of around 28 countries where the rates and the burden is the highest. When you look at the countries where the NCD burden amongst children is the highest, you get a different list. Right now, there's an overlap of around 5 countries that are common between them. And the reason I mention it is it's usually easy to convert geographically. That is not to say that the other 23 countries in the infectious disease list are not ones where there is some NCD burden and countries need to come together. But it doesn't make for a natural geographic convergence if you look at infectious disease burden and NCD burden. And that's, of course, the burden increases as the infectious disease burden goes down. Yeah, so with that, I will hand back to you. Thank you.
Thanks, Dr. Fouzia, Shafique, and I'll say a couple of words. I mean, because I think in the early morning, I'm very happy that many of you are able to join from this venue a little bit further away from the main venue, and that I hope that you're all energized with very interesting presentations from this morning. I want to share a couple of insights, summarizing what was said by Dr. Anamaria Bejar. I think we all see now and understand the link between NCDs and infectious diseases on the physiological terms, like how tuberculosis is linked to diabetes, how HPV can cause cervical cancer, how HIV increases the rate of hypertension, and how hepatitis also is one of the main causes of liver cancer. And Fouzia made an incredible presentation also bringing the link of infectious diseases and NCDs and showing the burden in low income countries where where action is needed, and very interesting overlap with countries. I want to say that this action is not only about naming, it's about doing, and primary healthcare is the main key for action. We see discussions moving more and more from vertical, siloed approach to more horizontal, and that's the main ask of the Primary Healthcare Coalition. We want to see systems being built. We want to see the capacity of healthcare systems being established, and that's the way to make it happen. I want to give one example before I give the word we move to the panel. There is a company, one of the largest pharmaceutical companies, which has proposed to donate insulin to 100,000 kids living with type 1 diabetes. And they had this program, they're working day and night, they cannot get a hold of the 100,000 kids. And there are more than that in the world. The healthcare system is not built enough to detect, to identify, to have those children's, countries are able to receive the insulin anytime. But if they don't know who are the children, if they don't have the healthcare systems to receive them, to deliver those medicines, that is not possible. So building healthcare systems is extremely important in this case. So with those words, I'd like to move forward to the panel with our host, Dr. Mancini from the Global Sepsis Alliance, who is going to be introducing the panel, and including one of his own boss who's here today. Thank you. The floor is yours.
Thank you, Rodrigo. Shall we invite all the panelists of the panel? We can introduce all of you. Please, welcome. Oops. Small. Here we go. Great. Good morning, everyone. And I am Simone Mancini I'm partnership lead at the Global Sepsis Alliance. The Global Sepsis Alliance is an organization based in Berlin. We're here in the panel, actually, the founder organization. We'll go to him. And of course, our goal is to raise awareness and to lead the advocacy about sepsis, which is one of the leading cause of death globally. So let me introduce the objective. First of all, the objective of the panel today would be a bit to deep dive on several aspects, thanks to the fantastic expertise of our panelists, of this link between non-communicable diseases and infectious diseases, and maybe try to identify solutions, how we can actually create the bridge and fill that gap. We'll try to do that in the next about 50 minutes. We want this to be an interactive panel. Therefore, please, here to the audience in the room, feel free to reflect and raise questions. And also, I invite the our viewers online also, they can post their questions or on the chat on the YouTube channel. So please help us make this interactive. And let me let me introduce the panelists of today. I have on my left, I follow this order, Kevin Tete from FIND. He's director of the Malaria and Fever Program at FIND that he joined in 2023. And previously, he was an associate professor of infectious diseases at the London School of Hygiene and Tropical Medicine. And he has a vast background on partnerships and with different worlds, academia, industry, and perhaps we will hear about that. Also, the important role of partnerships in bridging these gaps. We heard that, of course, we need to help health systems to make sure that we reach out to the population mostly in need. Kilian, do I pronounce it correctly? Kalian Kamenov from WHO is technical officer for disability. He joined WHO in 2016 and is based in Geneva, the headquarters, and is responsible for the development of normative documents and supporting member states in capacity building on disability inclusion in the health sector. And he also coordinated the development of several WHO publications, such as the WHO Global Report on Health Equity for Persons with Disability. And we're going to hear from Kalian about interesting initiatives that is working on the WHO to enhance equity. And Konrad, I know Konrad very well, and Konrad is internationally known as one of the champions of sepsis advocacy worldwide. Is the founder of the Global Sepsis Alliance and one of the initiators of the World Sepsis Day, and of course also co-founder of the World Sepsis Congress, which is an online congress happening yearly, attracting more than 11,000 participants every year. Is also chairman of the president of the German Sepsis Foundation, the Sepsis Stiftung, and member of the German National Academy of Science, Leopoldina. And beside Konrad, we have Margot. Margot is from the Access to Medicine Foundation and let me properly introduce Margot, apologies, and where she is Director for Government Engagement and Policies. She liaises with governments, private foundations, and multilateral organizations that are actively working to improve global health and access to medicines. And also she is responsible for the fundraising activities of the foundation. Margot has also very interesting background between ranging from research and policy position, including also an experience in the Ministry of Health and long-term care in Ontario, Canada. And last but not least, Professor Trenton White, postdoctoral researcher in the Public Health Fever Group at the Instituto de Salud Global de Barcelona and adjunct professor at the City University of New York Graduate School of Public Health and Health Policy. So Trenton also worked for the World Bank and for the US Agency for International Development in the past. So thank you very much for joining us. Let me shamelessly abuse of my power of as moderator to perhaps start with Konrad, not because I know him best, but because I think Konrad can help us actually really we have heard from a previous presentation about, the importance of connecting, thinking strategically about infectious diseases and NCDs, but also, how NCDs are actually connected, and the important look at it in a really strategic and holistic way. However, I think, Conor, what is the real actually burden? I mean, why infectious diseases and NCDs are so connected?
So first of all, let me say that I am very happy because I'm in the field since almost 40 years. This is the very first meeting where I have the feeling that all key actors that we need really to solve the issues. And this is not, we have here the issue of prevention, because infection prevention is sepsis prevention. We have here primary care physicians, and I'm so pleased that you now have initiative to work together on the global level. Why is primary healthcare so important? Because 80% of all infections derive in the community. For much too long, both WHO, the CDCs, the governments have been focusing on healthcare-associated infections, which of course, because they make up 20%, are also very important. And we can bridge and must bridge the knowledge, because overall, and you will see this data in the Lancet in September, 22nd of October by the authors of the Global Burden of Disease report, and Mohsin Najavi and Chris Murray, with who we work closely. Sepsis was also not on the agenda 10 years ago. Can you imagine? And what they figured out now, that in 2021, overall globally, we have 21.3 million deaths from sepsis and over 60 million cases annually. And this was a topic not on the agenda. The infectious issue primarily, of course, and we know from GAVI, so the success, what you this is primarily because you jointly achieved to prevent infections. And just to what I said, because it's poorly understood, and I would not criticize you, just to mention, because you mentioned in your slide that infections and sepsis make up 5% of all death. And at the same time in your slide you said pneumonia, diarrhea, and malaria contribute 10%, 15%. So what? It needs to be understood, and this is published since the late 94 or so, that sepsis is a common cause and the final common pathway of all infectious diseases. So it's also mentioned in the WHO sepsis resolution, which was initiated, and that's why we are sitting here, because we could convince our German government in 2016 to take the initiative for this. And I think it's important, and it's not about discussing NCD is, of course, it's 75% of all deaths, but half of these deaths are sepsis deaths occur in people with concomitant conditions. And the risk, for example, for a cancer patient is several times higher than a non-cancer patient, and for various reasons. So that's why I'm so pleased that we are sitting here.
Indeed, you really help, clarify what's really the link between, infectious diseases and the strong correlation. Margot, I know you also have other commitments afterwards, so let me make sure that we pick your brain on, you know, what do you think is critical to make sure, you know, that, you know, we break those silos that were mentioned before, from your perspective?
I don't know if this is on, maybe.
It is.
Okay. Yeah. And yes, apologies in advance. I will have to duck out as soon as the panel is finished because I have another speaking engagement back across town. But thank you very much for having me here today. So I am Margot Warren, the Director of Government Engagement Policy at Access to Medicine Foundation. And the Access to Medicine Foundation essentially guides and incentivizes the private healthcare industry to do more for access to medicine in low and middle income countries. And I think it's a really important component of this entire conversation here today because, as others previously in the discussions have highlighted, we are seeing a drastic decline in overseas development assistance. We are seeing now that ministries of health and governments in low and middle income countries especially are now being forced to really rely on their own budgets in a way that they haven't previously been sort of tasked with doing in many respects. So there is this pressure on health systems that is really growing and will continue to grow as ODA budgets continue to likely shrink. And that role then of these governments to support their own healthcare systems is incredibly important, and we need to be able to support them in doing that. And a huge component of doing that is making sure that the private healthcare companies, large pharmaceutical companies, medical oxygen companies, diagnostic companies, are all prioritizing access to medicine in these countries. There is a lot of sort of conversation around the role of the private sector at the moment. I think they play an incredible role in ensuring that there is sort of a strong and robust primary healthcare system in these countries. And we need to look at access to medicine as a holistic picture. It can't be sort of the way of the past where we've seen pharmaceutical companies focus on only one disease area. You know, we've seen in the early days of the HIV pandemic, companies kind of stepping up and in many respects due to very successful advocacy campaigns and very successful sort of pressure on the pharmaceutical industry to do more, we saw them lower prices for infectious disease medicines. We haven't seen the same sort of tremendous success in lowering of prices in the non-communicable disease space. So that is something that we've been working towards at the Access to Medicine Foundation, to continue to raise this as an issue, to continue to try to encourage the pharmaceutical companies that are in the scope of our research to really think of their whole portfolio, not just think of sort of one or two disease areas, but what can they really be doing across their relevant portfolios, both for infectious diseases and non-communicable diseases, and maternal and neonatal health conditions, and antimicrobial resistance, and all of the elements of their portfolio that would be useful for high disease burdens. And so what we are, again, encouraging them to do is to be proactive. When there is a new product in the pipeline, think very early on about access. What can you be doing to ensure that this new product, if approved, is registered in a wide array of countries where burden is the highest? Would you consider early on a non-exclusive voluntary license to enable generic production to make sure that volumes can really match demand? How are you thinking about last mile delivery? How are you thinking about sort of making sure that these products are available in the primary healthcare systems that need them the most? And I think that's a really critical component, again, of this whole conversation, is making sure that the products that are being developed and these medicines and vaccines and diagnostics are available in these health centers and are available at an appropriate cost. Because we already heard from the esteemed speakers beforehand that this is a critical issue as well. We know that there are these catastrophic health expenditures. We know that this can really cripple a health system if if we don't have appropriate pricing to make sure that procurement is possible. You can have a really efficacious, wonderful new medicine or vaccine or diagnostic, but if it's not affordable and it doesn't reach the shelves, then it's not going to be that sort of, wonderful new product that everyone was hoping for. If it's sitting on a shelf in a warehouse and not sort of in the hands of those who need it the most, then what is the true value of that at the end of the day? So again, I think when we are talking about this integration and when we're talking about strengthening primary healthcare systems, we really do need to think about how do we engage the private sector? How do we make sure that they understand what is expected? And how can we work together collaboratively to ensure that they are at the table, that they are thinking about access early on, and that they're thinking about access across their whole portfolios, not in this sort of siloed approach and only for specific disease areas. Thank you.
You raised also a very interesting point, and actually connecting with the current global context where governments need to operate, and many observers say, okay, but there's also an opportunity now, to when we look at reforms of the primary healthcare and how the healthcare system operate and how can they optimize their operation and budgets, etc. Kevin, Margot mentioned a very important point, of course. Medicines, but also diagnostics are, of course, key to, if we can pass the microphone to Kevin. What about the importance of diagnostics, of course, in NCDs, and what are the challenges there?
Thank you. Thanks for the invitation, and thank you for the question. I think that there are multiple challenges, and I can't go through them all, but I'll try and touch on some of the main ones. When it comes to sort of understanding, so I think diagnostics are the sort of tool that are often forgotten in the discussion. I think you've got the power of vaccines or drugs, because that is a very tangible and very important intersection of the healthcare cascade. But diagnostics kind of get forgotten as we go along those sort of discussions. And I think when you think that 7 out of 10 decisions that a clinician will make are driven by a test, you kind of think that you have to really think about the importance of that. But also, diagnostics have the ability to be able to generate a lot of data which can support surveillance, which cannot support targeting of drugs or targeting of vaccines, or really trying to think about how we might support health system strengthening. And I think trying to understand the type of information that we can get now from, Margaret mentioned, and I think someone else had mentioned climate. And when we talk about climate and the impact climate has in terms of driving diseases and really pushing that aspect, we then have to think about how we can look at that change and what it has in terms of intersection with non-communicable diseases. And I mentioned dengue, which was already mentioned by the previous speakers. And I think dengue is kind of the poster child for climate-sensitive diseases. And we knew during the pandemic that there was a lot of talk about underlying health issues, which are all tend to be non-communicable diseases, diabetes, heart conditions, etc., and the impact that the pandemic had or COVID had on those sort of diseases. A lot of that was already discovered or defined for dengue. So I think when we start talking about those challenges, I think those are some of the challenges we have to think about, is how we can look at really intersecting this much more clearly so that we can provide sort of synergistic help to the drugs, to the vaccines, to the control measures, and as we move forward. But I think one of the challenges is really the financing models. And I think this was touched on by Anamaria in her presentation. And I think the financing models are very siloed, and that means that it's very difficult to try and think about how we might look at these things in a more integrated or intersected way. And so I think with the changes that are happening in the global space and geopolitical sphere, that there is, this is catastrophic because it makes it very difficult for countries to be able to maneuver quickly enough. Most countries do not have that fiscal flexibility to be able to do that with the changes that have happened at the pace that they've happened. But we do have the opportunity now to be able to think, right, there's some significant negatives, but the positive is really trying to redefine how we look at that financing model with what money there is left, and think about how we can be much more efficient with what we can spend, intersecting much more collaboratively with our partners to be able to deliver the sort of healthcare delivery that we need. Thank you.
Thanks, Kevin. I would like to pass the baton to Professor White. Trenton, you also actually, indeed, so we're talking about really, prevention, diagnosis, the importance of it. Your work also focuses on, integrated screening, right? How do we make sure that that happens? Of course, in different contexts. Of course, there are, we have countries where maybe that is already happening, but where countries where actually maybe the tools are actually missing. How do we make sure that we fill that gap?
Thank you for the question, and of course for hosting this event today. I think it's very important. I want to first emphasize that primary care is the place where this artificial divide between infectious diseases and NCDs meets the people. And that's because people have overlapping needs and overlapping risks and overlapping burdens that primary care can help solve. So when it comes to integrated screening, I want to talk about my work in HIV and steatotic liver disease. Liver steatosis is not yet recognized as one of the major NCDs, although my group believes it should be, because nearly 1/3 of the population globally lives with liver steatosis, which can progress into advanced fibrosis and cause a myriad of problems like cirrhosis, end-stage liver disease, etc. So it's very, and more importantly, it's reversible until those final stages. So it's very important to catch it early. HIV, it was mentioned, is a driver of hypertension. It's also a driver of liver steatosis due to chronic inflammation. So what we're doing in Tanzania right now is piloting a program for integrated screening of people living with HIV and prediabetes. And I was very buoyed to see that slide by Dr. Shafique of the care continuum across the child's lifetime. I would like to emphasize that we should be doing integrated screening and integrated care continuums across the life course. We now use vaccines across the life course. That's common parlance due to GAVI and many others. So I would like us to start thinking about integrated care continuums across the life course.
Hello, Ian. I think you're best positioned to raise a very important point about, we're talking about all this, what needs to be done, what's important, what to make sure that happens. But an important element is about, equity, inclusivity. How do we make sure that we reach, everyone? Everyone actually has access to the care they need. I would be interested to hear about your work at WHO, because I think you're very interesting projects you're working on.
Sure. Thank you very much, Simone, and also thank you for having me here today. So I can answer your question in terms of what needs to be done with one word, and this is integration. But before I explain what I mean, just to maybe clarify first why you asked this question in the first place. And this is because there are millions of people in the world that are left behind by the health systems for different reasons. And I work in a WHO disability team, so I can talk, and my expertise is in with people with disability. But these are people that have a range of different NCDs or communicable diseases as underlying health conditions, and we know that they die earlier. We know that they have poorer health, and this is because of different health system barriers. It can be, from discriminatory policies to lack of accessible infrastructure to lack of data, or gaps in health service coverage. I mean, probably you don't know, but just for your information, in many countries, the gap the health service coverage gap between persons with disabilities and those without in terms of diabetes or cardiovascular health control is up to 45%. If we look at cancer, breast cancer and cervical cancer screening, it's 33%, and then immunization is 14% between people with or without disability. So it's really huge numbers that we're talking about. And going back to the integration part, I think the only possible way forward to address this issue and to have more inclusive and equitable primary healthcare systems is through integrating targeted disability inclusive actions within the health system strengthening efforts of countries. What this means is that for decades we've seen how disability has competed with other priorities like HIV, malaria, cancer. And if you have on the table policymakers discussing these areas and suddenly someone comes and say, hey, think about disability, it will never be prioritized. But if we actually integrate within these priorities specific actions to make systems more inclusive, then we will be more successful. For example, if a country X, let's say, in the next couple of years, invests heavily on 2 priority areas, capacity building of workforce or data, what they can do is, in terms of workforce, for example, include a module on disability inclusion as part of the mandatory education of medical students or training of health workforce. And it's not a big thing to do, but it will have a huge impact because the health workforce will be ready. They will have the necessary competencies and skills to address the needs of this population group, and this will have a huge impact. Or data, if the country, for example, is expanding their indicators to track population health, what they can do is to include a couple of questions to identify who in the population has disability as part of the routine health information system. And then they will know, are these people sicker, why are they sicker, and what we can do about it. So, and just to say that it's not just about what we need to do if we want to have a more equitable primary healthcare systems, but it's also a smart investment. At WHO, we have done a series of economic analysis to show that if you deliver these services like NCD prevention or immunization for children or cancer screening in a disability inclusive way, for every dollar invested, you get a substantial return. I mean, for only taking the example of NCD prevention, it's up to $10 for every dollar invested. So it's a substantial return on investment. So not just what we need to do, but also an investment for governments.
Yeah, very good point. Thanks, Royan. Conrad, I wanted to come to you as well, but I see you want to react perhaps to something that was mentioned.
Yeah, just to reiterate this point that we need really to cooperate. Dr. Tedros has rightly said, nobody should die from infection/sepsis. And it's preventable, but we need also educate those who are at the highest risk. And these are the very young, those with concomitant diseases. And of course, it depends, as Margaret Chan has rightly said, in the context of Apollo, it's poverty, and which means also the capacity of the healthcare system. And just to let you know that it's not only poverty, because there are countries in Western Europe, including my country, where the death rate per 100,000 population is in the same range as in the US, and this is again which is as high as 250 per 100,000 population. And there are countries in high income, as in Australia, this is 109 deaths per 100,000 population. So the resources which are available in these countries are similar. But it's a question of governance, of leadership, of the quality of the healthcare system. And of course, there are countries in sub-Saharan Africa and in Asia where sepsis makes out now 70% of all deaths. And it was demonstrated already in the US that from 1900, the crude mortality rate from infectious diseases / sepsis has decreased from 800 per population until 1984 to 30,000 population. In the meanwhile, it's again, as I mentioned, also in the US at 250 per 100,000 population. And we know how to change this, but our political leaders and the government are not strongly enough on health as such, and it's such an important health economic issue, as it was rightly said, and just the figures for Germany, we spend annually more than 30 billion euros for sepsis and its sequelae. And as it was mentioned, every investment, there's data from Canada, also from Australia, it's a several time of return of investment in terms of prevention, and this is badly needed.
Interesting point. I will ask Margot to follow up on this, because so there's clearly an issue with awareness, of course, but there's an issue of political will as well to execute, to put in place certain processes, policies, frameworks to make sure that those reforms are put in place. What, perhaps also from your background in policy as well, is that your experience as well? Is there a need to create that political awareness as well to ensure that certain this gaps is filled, and actually this is a priority. This is made a priority in certain countries.
I mean, ultimately, you touched on also collaboration, and I think there is, of course, political will to try to create, as robust of a health system as you can, given fiscal constraints. I think, if you ask any Ministry of Health, what keeps them up at night, I'm sure it's their budgets. I'm sure it's a lack of budget. I'm sure it's, we talked about catastrophic health spending. How do you balance, being able to treat your population with a really important product, or a large set of really important products, but they're very expensive. And in reality, if you utilized a different product, you could treat many more patients for something else, for another condition. It's very difficult for ministries of health and for governments to balance all of these different competing priorities, especially when costs are sometimes astronomical. So I think there's also a growing political will to explore partnerships, to see where there can be really unique collaborations, to understand the role and the influence that governments have when it comes to procurement, when it comes to capacity building initiatives, and when it comes to true partnerships, and understanding how can you support additionally regional manufacturing, how can you support generic production, not just within your own jurisdiction, but sort of on a global level in which you could procure at, of course, from a generic perspective, a much lower rate than if you could procure from an on-patent product company. And so I think what we're seeing and what we have seen unfold in the aftermath of the COVID-19 pandemic is this renewed sort of commitment to partnership. And the Access to Medicine Foundation hosts a variety of roundtables. We refer to them as Amsterdam sessions. They're not always in Amsterdam, but our organization is based in Amsterdam. So these sessions are intended to bring all of these partners together, to bring large R&D-based companies, generic manufacturers, governments, procurers on the ground, different multilateral organizations, and really work through some of these access challenges together. And we did one actually in 2021, looking at some of the lessons learned from COVID. And what we found, to be very clear from the conversations, was that partnerships was incredibly important before a pandemic breaks out, before there is an outbreak of infectious diseases, because once there is a significant outbreak, it's too late to start building those partnerships. You need to have them in place already so that you can draw on them in a time of crisis. And I think when we're talking about strengthening primary healthcare systems, again, making sure that those partnerships are in place early on is really tremendously influential and important. And connecting the dots for people, making sure that we do have sort of sources of affordable medicines, whether that is a discounted price from a large R&D company, or whether that is through the use of a non-exclusive voluntary license so that you can procure a generic variation. There are lots of mechanisms at play, but you need those partnerships to exist. And I think governments play a tremendous role in facilitating some of those partnerships and encouraging those partnerships and sending the signals that are needed to foster and really ensure that those partnerships grow and be part of them and all be sort of at the same table working towards the same goal. And that's where I do see a tremendous amount of political will shifting and being more open to having some of these conversations. And on the other side too, I think there's tremendous will from a lot of the pharmaceutical companies to explore some of these options in ways that they haven't necessarily done so in the past. So in that respect, I know it's in the global health sphere, it's a tumultuous time to say the least. But I do think there are some points of optimism when you think about the opportunities that can arise in this sort of storm that we're weathering at the moment. And I think private sector engagement and private sector accountability is a hopeful element of what we can see in this difficult time.
Thanks a lot, Margot. You stress a lot about the importance of partnerships. And in fact, I think in the current context, of course, that has become kind of like a must where we all need to look at, share resources, share intelligence, share and efforts, and I think also industry is become an even more important partners for health systems. In fact, on these themes about partnership, I would like also to perhaps conclude this round of questions through the panels, and then actually I will remind the participants here and also online to think about any question you might have. You want to raise. Kevin, yes, partnerships, the role of industry, also like in diagnostics. Tell us why is this important and what can be done?
Sure. Thank you. I think so. FIND, Foundation of Innovative Diagnostics, is a PDP, or a product development partnership. We cannot do what we do without partnerships. We cannot. There's many of us in that space. The partnerships are essential. Partnerships with countries. So if we want to, if you're talking about delivering a new diagnostic, you really need to have that country engagement. You have to that community level engagement, because if you don't, you can come up with whatever fancy piece of kit you want, but if the country doesn't need it or want it, it's not going to be taken up. So those kind of partnerships, right from the grassroots, right through to governments, and you need governments involved, because otherwise it's not sustainable. You can get something off the ground, but if you don't have that government engagement, it's not sustainable. So when we talk about partnerships, it's a very broad church. We have interactions with academia, we have interactions with developers and manufacturers, because we've got to talk to them about what is needed, feed back to them what the country partners want, and then think about what that tool will look like and also what the cost implications would be like. So cost has come up a number of times, and it's a big driver, and we need to think of a way how to control that. But you've got to get a balance between what the manufacturers need to be able to survive and what the country partners are able to pay. And so that's obviously quite a tension between the two. But again, you engage into that with partnerships, and you've got organizations like the Global Fund, who are really sort of a big umbrella partner and able to sort of drive these sort of pricing sort of discussions in that space. So yeah, I think right from the grassroots, right across to multilateral organizations and governments, those sort of partnerships are essential to be able to move forward and to be able to build sustainability into a lasting measure. Thank you.
Totally, and involvement of actually other global actors. You mentioned the Global Fund or GAVI or other organizations. I think it's very important. Kaloyan, I wanted you to mention in terms of partnership, like multi-actors, multi-stakeholders partnership, what you do with WHO in terms of for disabilities. I think that's a great example of things work and actually help develop actually these policy frameworks that can be put in place.
Thank you. So partnerships are also essential for WHO. In the past years, we have really tried to strengthen our partnership with civil society organizations because we believe that civil society can be a really catalytic power in terms of creating demand for countries. And just to give you a practical example of what this would mean, and this means actually, Sightsavers, they're here in the room, one of our closest partners. They were really a fundamental factor for some of the health system work in several African countries like Cote d'Ivoire or Nigeria, where through organizing policy dialogues, involving ministries of health, WHO, other partners, now these countries are undertaking health system strengthening work in terms of PHC work and being integrating some disability inclusive measures in their health agenda. And this has really been successful and shows what the power of civil society is. But also ministries of health, they cannot really do the job on their own. They need to partner with academia, with civil society, with the UN, with private sector. And to facilitate this process, we launched very recently a Global Disability Health Equity Initiative at WHO, which is very similar to other WHO initiatives like the UHC partnership, for example. And this provides member states, academia, civil society, private sector, donors a platform to work collaboratively together to ensure that health systems are more inclusive, more equitable. And we have had really an incredible response already. We have 145 member organizations, a lot of member states, a lot of disability actors, but what we're still missing are some of the health actors that are here in the room. And I'm using this opportunity just to say that, if the only way forward to have more equitable health systems is if disability actors and health actors work together. So you're more than welcome to join the network. And, after the session, I can provide more information if needed. But I think that this is a good platform really to make this happen. So, yeah, thank you.
Thanks for this, call or collaboration. I hope more organizations pick it up. Triton, there's one question actually I wanted to ask everyone, but I think I'll start to you, and or maybe only to you, because then I want to open the floor as well. You mentioned HIV before, right? And of course, I mean, this, the fight against HIV is something that started, long time ago, and I think we all have learned from it, and now life expectancy is improved, screening, everything, screening, treatment, and everything has improved. Is it something that we can learn from that, long-term fight that we can apply to, in the current context?
Absolutely. I think we already have learned a lot of lessons from HIV that we are applying to public health and primary care. One, the meaningful involvement of people with HIV is now a mainstay of nearly every disease platform that I can imagine. We have to meaningfully engage people. I know it started with activists in New York and San Francisco saying nothing about us without us. And I think us in public health have really learned that lesson. Two, I mentioned the continuum of care. We have taken lessons in public health from that experience in HIV, that we need to have data at every point in that continuum of care so that we understand where we can intervene, how much it will cost us to intervene, and what we will gain from intervention at every point, not to lose people in that continuum of care. I want to come back to the policy for a moment as well, because in my courses on public policy analysis, I teach my students the ABCs, which we all know are ABCs, no? That when you go to a policymaker, you need to have 5 things with you. Oh, they need to be aware of your disease, and typically we stop at awareness. But you need to bring with you budget. Do you know how much you're asking for? Do you know where you can get the money from if the policymaker does not have extra budget? How will you raise those funds? See the cost of inaction. So every policy or every intervention has the option of the status quo being the policy, and often that's the easiest policy route for a policymaker to take. So make sure that they know the cost of inaction, the data. What do you have recent data? Do you have ongoing data collection to monitor the intervention and the policy you want to implement? And elections. We often forget that policymakers are driven by elections. So know when to ask and know what to ask for at the right moment.
Thanks, Leton. Very important points. We need to bring this panel discussion, unfortunately, to a close. First, so I'm sorry, Rodrigo, if I'm picking a couple of minutes from your conclusions. I just wanted to, give a chance to the audience here to see if there's any questions you want to ask our panelists. Yeah, thanks, Margot. Yes, thank you for your contribution. Thank you. Yes, there's one question here. It might be the only one for the interest of time. We got one.
I do not have a question, but I do have something to add to the conversation. I am Corazon Aquino. I am the Partnerships Manager with Amref Health Africa. I'm also the Acting Global Partnerships Director. I'm very honored to be here and to participate in this conversation as a participant, but then also as a co-host. So Amref Health Africa's mission, it is the largest health NGO in Africa, and our mission is really rooted in community-led, people-centered primary healthcare systems. So this is something that is very close to our heart, and we've been championing this because we've seen firsthand how fragmented health systems really undermine the resilience of the health systems. And so it's the same case as NCDs and infectious diseases. And we are really championing for integrated healthcare service delivery. And so currently we are working on what we are calling the PHCC accelerator model that is really looking at working with governments within their context to come up with models or solutions that are contextualized and nuanced to the needs of the community and the needs of the countries that they work in. And it's something that we've started and continue to do. Again, that's not happening in isolation. We are currently leading the charge in rethinking and reimagining the global health reform. And really convening different voices from the continent, different stakeholders to reimagine what the future of global health should look like. Of course, given the fact that we really stand at a defining moment and we cannot continue to do business as usual. It is not sustainable, and we have to change to be able to get the better health outcomes that we really are looking for. So this week, we are convening different stakeholders from the different subregions of the continent, North, South, West, and East and Central, to really flesh out those bold ideas of how the future of global health should look like. And then later on in the month, we will be having a convening somewhere in Kigali with now all the stakeholders from the different subregions meeting in person to, sort of validate what will have come out of the virtual consultation. So it is really a process, and we're looking forward to, continue to partner with IDA and the other like-minded partners to chart the way forward in terms of global health reform. So I was very excited to listen to the insights from the panelists and the recommendations. And yeah, thank you.
Corazon. And I think maybe there was someone else who wanted to take the floor. I don't know, Rodrigo, if you have time for that. No? Okay. Then, then I would like to thank the panelists for this very rich and insightful discussion. Thank you so much. I think what Conrad said, I think this kind of meetings are very important. I think we have very good, wide range of stakeholders, and I think we really need to keep on, having this kind of discussion, solution focus, of course. And I think the World Health Summit provides a good platform. So I'm sure we will see many of you in the next couple of days. Thank you very much.
The panelists, thank you for your participation. I would just close the event. You're welcome to also have a seat. We have coffee and some snacks for you for networking just after the session, so that you can keep your motivation for the last couple of minutes. Thanks everyone for joining us here today in Berlin and online. It has been a very insightful session. We have heard words about affordability and access to products through Margot. Kalian was saying about the focus on vulnerable populations. Then Professor Konrad Reinhardt was focusing on, of course, the link to infectious diseases and NCDs, and the fact that sepsis is a very important killer, especially in low and middle income countries. Kevin was, of course, touching the points of diagnosis, which is key to treatment of any diseases, in that partnerships is extremely important in action. I think was a point also mentioned by Corazon from Amref. Then we have Trenton focusing on, of course, the patient-centric approach and listening to patients, and of course the policy aspect. We all understand it's very tricky, and very good 5 points that we are taking home from that one. So I want to thank all the participants for coming, and the speakers to sharing our insights with us here today. I might have some slides left. So I went too fast. Yes. So as we conclude this crucial side event, I would like to thank all the panelists and participants for your invaluable contributions. Thank you for joining us here today. We have heard an incredible panel, and I would like to present here some takeaways from today. And there is a joint statement, break the silos for integrated healthcare systems. So the first one is, of course, to prioritize integration. Make NCDs and infectious diseases integration central for policies, financing, and health system design. Advance equity, I think was a point very well raised by Kaloyan, ensuring care reaches the most marginalized communities, women, children, persons with disabilities, and underserved communities. Then foster collaboration, align government, civil society, multilateral actors, and private sector for collective impact. I think it reflects a lot to what Kevin was saying. Drive innovation, invest in diagnostics, data, and digital solutions to strengthen integrated care. Mobilize will, elevate integrated primary health care on political and public agendas to secure lasting commitments. So please feel free to come out to our websites to understand more what we're doing on Primary Health Care Coalition. Let us leave here with a shared commitment to break down the traditional silos, align efforts to across infectious diseases and non-communicable diseases, and ensure that primary health care is truly the foundation of resilient and inclusive health systems. So there's a link to the joint statement. You can also find it online, but with your phones you can access to the QR code. I would like not to take so much time. The time has a little bit passed by 1 minute, but to invite all of you that are interested in the Primary Healthcare Coalition to visit our website or to talk with us here today. We have 6 colleagues from the Primary Healthcare Coalition here. We are open for membership, and yeah, that's a very good opportunity for us to continue working together. And I would like to invite you for a networking session in the back. And just thank you for you being here today, and have a great World Health Summit moving forward. Thank you.